Hello, I'm Dr. Richard Alcorta, the Acting Co-Executive Director and State EMS Medical Director for MIMS. I'd like to welcome you to the Maryland EMS Update for 2017, which includes the revisions and additions to the 2017 Maryland Medical Protocols for EMS providers. MIMS, the EMS Board, and the citizens of Maryland thank you for taking the time to complete this Maryland EMS Update, as it advances the practice and delivery of EMS services across Maryland. Through this educational process and annual protocol update, Maryland is able to stay current with the advances in EMS care. I'd like to highlight several pilot protocols underway that I believe will advance the national practice of EMS. One such current pilot involves Baltimore City EMS and Sinai Hospital neurologists. An EMS provider who identifies a patient having a positive Cincinnati Stroke Scale score and who will be transported to Sinai Hospital will have EMRC connect them online with the base station and simultaneously the on-call receiving neurologist. The EMS provider will complete the patient assessment, and then the neurologist will call the patient's designated family member. The purpose of this research pilot is to determine if having a neurologist online in the field who initiates a pre-arrival conversation with the patient's family will shorten the EMS contact to fibrinolytic time for stroke patients. MIMS has approved 2 additional pilot protocols. First, Montgomery County is evaluating an alternative destination screening tool to determine if a patient can be transported and managed safely at an alternative non-hospital-based destination. Second, Maryland now has 4 mobile integrated community health or MIC programs underway in an effort to meet the needs of patients who have requested EMS service assistance multiple times in a relatively short time frame. A nurse practitioner and a paramedic will visit the patient at home and provide a home safety check, patient assessment, and referrals for medical or social support resources as needed. These programs are administered by a medical oversight committee with EMS, health department, and hospital system representation. These are exciting times for Maryland and the healthcare system, and Maryland needs to be innovative and creative to meet the challenges. This year's protocol updates will be much shorter, and I will try to summarize the essential elements for you as base station staff. The 2017 Maryland Medical Protocols for EMS providers includes a new syncope protocol. After reviewing the evidence, the system has identified that many syncopal individuals need additional evaluation. Patients who have had a transient loss of consciousness really need to be assessed by advanced life support and have a 12-lead EKG performed. Next, I'd like to highlight that the governor's appointed Sexual Assault Medical Forensic Committee, which was founded in November 2014, has generated a report that I believe will improve care for patients who are victims of sexual assault. Many of you currently practice at a Maryland Coalition Against Sexual Assault or MCASA recognized facility. The Maryland protocols will now direct patients who meet criteria for sexual assault to one of the MCASA recognized facilities. It will improve the forensic investigation, collection of evidence, and reduce the interfacility transfer for this population. Please realize that even though you may not be an MCASA recognized facility, you are still required to perform a screening exam. You must offer to notify law enforcement for the individual, and you may have to collect forensic evidence. For patients with a positive Cincinnati Stroke Scale score and with a suspicion of having a stroke, there will no longer be a fibrinolytic checklist performed by EMS providers in the field. This does not prevent providers from doing a fibrinolytic checklist for the ST elevation myocardial infarction patient, as the criteria is much narrower compared to the more complex stroke assessment for administration of fibrinolytics. Two medication modifications have occurred. One, terbutaline has been removed from the Advanced Life Support formulary and will no longer be on EMS units. And two, an ALS provider who activates the bucking protocol for an intubated patient, when the patient is starting to become more responsive and fighting the endotracheal tube, can now administer Versed without medical consultation. This change will reduce the need for you to give that order. There is a new protocol that addresses carbon monoxide and smoke inhalation. The key elements of that protocol are to identify patients who meet a certain sign and symptom threshold and need to be referred to hyperbaric therapy versus patients who simply need high-flow oxygen or the administration of a cyanide antidote. The new protocol has a field set of criteria with some new optional detection devices that will help EMS providers assess the severity of either carbon monoxide or the presence of cyanide with an external detector. We realize both of these devices are colorimetric in nature and may have some limitations, but they have been demonstrated in the literature to be useful preliminary assessment devices for implementation of either hyperbaric or cyanide antidote administration. There's been a change in patient priority acceptance for freestanding emergency medical facilities. There are currently 3 recognized freestanding emergency medical facilities in Maryland: University of Maryland Shore Health at Queenstown, Bowie Health Center, and Adventist Healthcare Germantown Emergency Center. A pilot protocol program at University of Maryland Shore Health at Queenstown demonstrated that stable priority 2 patients can be identified accurately by EMS providers and transported selectively to that facility instead of continuing on to an inpatient-capable hospital emergency department. The success of the pilot program generated a change for the freestanding emergency medical facilities, which are now permitted to handle stable priority 2 patients. Although the termination of resuscitation, or TOR protocol, is designed for patients 18 years of age or older, there are rare instances in which a child under the age of 18 clearly has died in the field. Our protocol historically did not allow for either the provider to pronounce death or a base station to provide permission to withdraw care. There has been a new alert placed in the termination of resuscitation protocol that reads as follows: if patient has not reached their 18th birthday, termination of resuscitation may be considered in rare circumstances. Contact a pediatric base station at Johns Hopkins Children's Center or Children's National Health System for online medical direction prior to termination. If online consultation with a pediatric base station is not possible, treat accordingly to appropriate protocols. This means that EMS field providers should be consulting directly with one of these 2 pediatric base stations if they believe they need to withdraw care for a child who has died in the field. As a practicing emergency physician or nurse, you get to see medical orders for life-sustaining treatment or MOLST forms on a regular basis. It's important to realize that the sending nursing home facilities, as well as the hospital inpatient discharge to a nursing home facility, must have a MOLST form sent with them. This does not apply to observation patients from the emergency departments. Under the existing COMAR regulations, a nursing home or assisted living must, not may, send a copy of the MOLST form with EMS providers, both public safety and commercial, whenever they are transported to a healthcare facility. As a reminder, electronic copies on a computer or device are acceptable for initiation of care. However, a hard copy must accompany the patient when transported or transferred between facilities. Hearing from the Maryland chapter of the American College of Emergency Physicians that many of our patients are being placed on EMS DNR MOLST no CPR Category B palliative care only when they actually have a reversible underlying condition and the patient would like to have that condition addressed. Therefore, they should really be on EMS DNR MOLST no CPR Category A1 or A2. This would allow for you and EMS providers to appropriately resuscitate the patient. For example, a hypoglycemic diabetic patient, a MOLST Category B cannot receive IV dextrose. But if they were an EMS DNR MOLST no CPR Category A1 or A2, they could be given dextrose. This is an opportunity for you to provide re-education to those primary care clinicians that you interact with on a regular basis. The physicians that manage inpatients may also come to you for clarity on their legal obligations related to MOLST. The patient who is discharged from inpatient, not the emergency department, and not from observation situations, and who is being sent to a nursing home facility must have a MOLST form accompany them. This means that inpatient physician must have the MOLST discussion and complete a MOLST form. Next, I'd like to refresh you on the patient-initiated refusal protocol. I still get multiple questions from physicians and nurses alike asking why an EMS provider is calling a base station when the patient is trying to refuse care and/or transport. I'd like to emphasize the reason the EMS providers are calling you as the physician. It is to recruit you in their efforts to convince the patient, based on the information you receive from the EMS provider, to accept EMS care and transport. The EMS providers are uncomfortable leaving patients on scene with an against medical advice. Patients may be more likely to accept physicians' advice, given their influential and respected positions in the medical field, to receive care and transport to the hospital for evaluation. I'd like to emphasize the consult is not, repeat, not a process for approving a patient refusal. This is not putting you at a liable risk. You're attempting to convince the patient to have care given to them in the emergency department. Please engage the patient in that dialogue and do not attack the EMS provider on why they're calling you on a patient-initiated refusal. The County Hospital Alert Tracking System, or CHATS, and its appropriate use are important to Maryland's EMS system. However, there is evidence that several hospitals are not using the system correctly. As you may be aware, we have had significant periods during which multiple hospitals are on red, yellow, or reroute alerts. I'd like to first bring clarity to what these three determinations are and how they are used and put into place. First, yellow alert is an alert that the hospital voluntarily places themselves on. It's triggered when the emergency department is in a state of overload but is still open to priority 1 patients. The decision process for placing a facility on yellow alert varies from institution to institution. Often, the charge nurse in the emergency department works collaboratively with the lead emergency department physician on determining if the emergency department is overloaded or overwhelmed, and if it should be instituting the yellow alert. A few institutions require administrative approval before the hospital will go on yellow alert. The yellow alert policy for each region in Maryland states that if the next nearest hospital is also on yellow alert and there is not a reasonable transport distance to the next closest hospital not on yellow alert, the yellow alert is negated for the primary hospital to which the EMS provider would normally transport to. Therefore, when things become stressful and multiple facilities are on yellow alert, don't be surprised when you get a priority 2 or priority 3 patient, even when you are on yellow alert. There's no reason to be upset with the EMS provider when this occurs, as the CHATS board always lists alert status of the hospitals near your facility. And if asked, EMS providers will tell you that the other facility is on yellow before you get a patient. For hospital systems, it's important to understand strategies on improving throughput. How you improve throughput either through discharge or rapid transferring of patients to inpatient facilities is critically important to maintain patient care flow. I understand this is a patient care institutional challenge. In response to this challenge, several facilities have established pre-yellow alert notification within their facility to 1, add staff to the emergency department, 2, make beds available for inpatient placement, 3, apply the Stony Brook model for alternative locations such as hallways as temporary holding locations for patients. Red alert is when you have no inpatient monitored beds, but this does not include the monitored beds in the emergency department. You do not have to have all beds filled to get on red alert. When a hospital has no ICU or CCU beds, but their emergency department is not full, the threshold for going on red has been reached. The hospital does not have to wait until critical care patients are lined up waiting for beds in the emergency department. Red alert is frequently misapplied in this situation. And there are occasions in which the hospital has no beds, but has not placed themselves on red alert. Please realize when EMS is looking at interfacility transfer for patients, particularly from a freestanding emergency medical facility that does not have inpatient capability, they're looking at CHATS to identify the next most appropriate facility for ICU transfer or admissions. Realize the use of yellow and red alerts are totally within the control of the hospital. Please talk with your administration and those making the decisions on yellow and red alerts about using them appropriately. When the yellow alert has failed, as in ambulances are lined up waiting to offload patients, or when the facility has decided it will not place itself on yellow alert, EMS operational programs have a process for placing your facility on reroute. When that occurs, you will get no ambulance traffic from any EMS service or county. You should clearly understand the difference between yellow alert and reroute. Yellow alert allows for priority 1 and specialty referral patients to still come to your facility, while reroute means you're closed to all EMS patients, no matter the priority or if they meet specialty center criteria. In other words, being on reroute means all patients are diverted away from your facility. I want to take a minute to discuss in detail the effect of being placed in reroute status. A single county EMS operational program can activate a reroute status for a hospital if multiple units are waiting to drop patients off and the wait is more than 20 minutes. This wait time seems to be the norm these days in some facilities, which I feel is unacceptable. It's clear that this handoff process needs to be streamlined. You're impacting the EMS operational program's ability to respond to 911 calls by tying up their ambulances waiting to offload patients at their facility. One of the challenges a hospital has when they have been placed on reroute by County A is that it also potentially impacts receiving transports from County B and County C. No units from any of these counties will come to your facility while you're on reroute. Furthermore, County A is the only service that can lift the reroute status for your hospital. Ideally, the EMS service will notify the charge nurse that County A placed them on reroute and whom to call to lift the alert. If this has not occurred, pick up the EMRC red phone and ask the EMRC operator to reach out to the service that placed the hospital on reroute. That county's EMS service is the only one who can take you off reroute status. In rare instances, hospital administration has prohibited activation of any alert status for their facility. In many respects, this has a negative downstream effect on EMS and the emergency department patient care flow. The lack of participation in the CHATS system when patients and ambulances are lined up in the emergency department forces EMS to use the more aggressive reroute policy. In turn, this increases transport times and has the potential to negatively impact outcomes for patients. What do you do when a hospital infrastructure fails or has some significant or catastrophic system failure? Pick up the MRC phone and request being placed on mini disaster status. As the state EMS medical director, I must approve this request before the EMRC will place your facility on mini disaster. I will call you promptly and ask you to find your problem and ask, do you need state assistance? For example, your hospital has had a power outage due to a transformer damage with intermittent power surges that interrupt your generator's activation. Mini disaster status was requested and would be approved for this indication. The Department of Health and Mental Hygiene and the Maryland Emergency Management Agency will be notified, and this status will also be broadcast to health and emergency management leaders. This mini disaster approval means you will get absolutely no EMS transports, no specialty care patients, and no interfacility transfers to your facility. Destination determination assistance is a common reason for calling the base station. There are occasions when an EMS provider will call and ask for a dual consult, one with the Specialty Referral Center and one with the nearest local emergency department. This is a professional, collegial exchange in which the EMS field provider believes the right destination is the Specialty Referral Center, but is not sure. In some instances, the provider is requesting aviation for transport, so they need to have a definitive destination. As the local emergency department, after hearing the information relayed by the EMS provider, you have the authority to say that you believe the right destination is the Specialty Referral Center. For example, you may not have orthopedics readily available on call for a femur fracture from a motor vehicle crash. If that is indeed the case, please advise the Specialty Referral Center so that they can accept that patient. This should be a collegial decision, not a competition for the upper hand or which facility has more authority to decide the proper destination. The appropriate destination is established by the state EMS medical director and per the CDC and the American College of Surgeons for the patient who meets trauma decision tree categories either Alpha, Bravo, Charlie, or Delta should be a trauma center. Only if there is an airway issue or some emergent intervention needed should the patient be redirected to the local emergency department first. Please be aware of this and work in a collaborative way and offer candid advice to your specialty center colleagues. Also, for those of you at specialty referral centers, consider the resource availability both at the local emergency department and particularly the rural EMS operational programs in your decision making. For specialty referral center physicians, it's important to understand that you must, quote, consider medevac transport if ground transport greater than 60 minutes to a trauma or specialty center would deplete the limited EMS resources in the community. In some of our community EMS systems, only 1 or 2 advanced life support transport units may be actively available. An out-of-service time of an hour to your facility, 20 to 30 minutes handoff, and an hour back to their first due area has the potential to cripple the local 911 system. Please approve the use of medevac for these rural services. Regrettably, we're in the midst of an epidemic. Your first thought may be I'm talking about a pandemic flu. I'm actually speaking to you about patients with dependency and addiction on opioids. In Maryland, we're losing 5 lives a day to prescription and illicit opioid overdoses. Naloxone in the hands of law enforcement, EMS providers, and civilians is a partial safety net for these individuals. Many of these individuals overdose 2 or 3 times and are encountered by EMS or emergency departments frequently. A single overdose is one of the strongest indicators that these individuals will eventually die from an opioid overdose. The window of time to educate or intervene is at the time of survival after a near-death experience from an overdose. This is an opportunity for all of us to identify the individual and refer them to rehabilitation and supportive services. Lieutenant Governor Rutherford's Heroin and Opioid Emergency Task Force report was released on December 1st, 2015. Please take the time to obtain and read a copy of this report. The Secretary of Health, Dennis Schrader, working with the Emergency Management Agency, has also just implemented an Opioid Operation Crisis Center work group in an effort to reduce the deaths and disability we are seeing associated with both prescription and illicit opioid dependency in Maryland. We have an opportunity for both EMS and base station facilities to improve outcomes for these patients. In summary, thank you very much for providing base station medical consultation and supporting the EMS providers who are responding to a spectrum of 911 calls. With your assistance, EMS is able to transport patients to the most appropriate facility for the optimum patient care, which in turn reduces morbidity and mortality. The staff at MIMS, the EMS board, Pat Gaynor, and I, as acting co-executive directors of MIMS, wish to thank you for all you do to make Maryland's health care and EMS system as robust as it is.